Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today is part 2 of our discussion on adult Hodgkin lymphoma. In the previous talk, we really went into an overview focused on the staging and some details on the treatment paradigms. In this talk, we will be getting more into the actual evidence and the clinical trials that guide our treatment paradigms. As we discussed in the previous talk, Hodgkin lymphoma is typically divided into 3 different treatment groups, or 3 different risk groups, I should say. So early stage disease is divided into favorable versus unfavorable. And early stage disease typically means stage 1 to 2 disease, so think of disease on one side of the diaphragm. And then advanced stage disease, so disease either on 2 sides of the diaphragm or with a lot of extranodal involvement, that's considered stage 3 to 4 disease, and it has its own treatment paradigm. For dividing early stage favorable versus unfavorable, different study groups, such as the German Hodgkin study group as well as EORTC, will have different criteria for making a patient unfavorable. And really, those criteria have to do with the inclusion criteria for the different studies. So in the overview talk, there's a nice table from NCCN that sort of outlines what those risk factors are and how the Germans versus EORTC, how they kind of separate favorable versus unfavorable, and we will review it too when we review the trials, kind of what these criteria are. But keep in mind that whatever criteria you use to kind of divide a patient into a particular risk category, you should use that same study group's criteria for treating the patient. So what I'm trying to say is if a patient is considered unfavorable by the German Hodgkin study group criteria, then they should really be treated as per the German unfavorable treatment paradigm. They should not be considered unfavorable by German, but then treated by the EORTC paradigm, is basically what I'm trying to say. The other note that I will make is, a lot of these historic studies that we're going to talk about, they utilize a radiation modality called IFRT. It's the same exact radiation, but we're basically saying involved field radiation, or IFRT, meaning that we're not just covering the particular area that was involved pre-chemo, we're covering the entire field. So even if there was just one cervical node, they're covering the entire cervical chain. And that is really what was used historically. In the modern era, involved site radiotherapy or involved node radiotherapy are accepted as standard. In the US, typically we just use ISRT. Involved nodal radiotherapy requires having the pre-chemo PET CT in the radiation treatment position, whereas involved site radiotherapy does not. So for purposes of board exams and things like that, especially for folks in the US, it's very safe to say ISRT as your radiation modality when you're asked. Let's begin by diving into the evidence for treatment of early stage favorable disease. So just to review, here is the table of unfavorable risk factors for early stage disease for the different study groups. So we're actually going to start by talking about some of the trials from the German Hodgkin study group. So for a moment, let's just focus on those risk factors. So in this table, in that first column, are all of the risk factors for the German Hodgkin study group that make you unfavorable. And so in this section, we're really focusing on favorable disease. So think of favorable disease by German criteria to be disease involving only 1 to 2 nodal sites, no extranodal lesions. The mediastinal mass ratio has to be less than 1/3, and the ESR is low. So that's defined as less than 50 if they do not have B symptoms or less than 30 if they do have B symptoms. But 1 to 2 nodal sites, no extranodal involvement, low bulk, so that mediastinal ratio is low, and the ESR is low as well. The German HD10 is the first trial to know about, and they basically took patients with favorable risk Hodgkin lymphoma, as defined by the risk factors that we just previously discussed, and they performed a 2-by-2 randomization. So they were first randomized to get chemotherapy with ABVD, for either 4 cycles or for 2 cycles. And the cycles were given in monthly cycles with infusions on days 1 and day 15. And so they were first randomized to either 4 cycles or 2 cycles of ABVD. And then 4 to 6 weeks after completing chemotherapy, there was a second randomization to either involved field radiation for 30 gray versus 20 gray. And remember, involved field radiation is what was used in a lot of these older trials, but we now know from our ILROG guidelines that that is an outdated technique. It just gives too much radiation to too large of a field. We have now narrowed down our fields to involved site radiotherapy. So it's safe to kind of apply these treatment paradigms knowing that the studies used involved field radiotherapy, but in the modern era, we use involved site radiotherapy. Anyway, so 2x2 randomization, ABVD times 4 versus times 2, and then 4 to 6 weeks later, either radiation to 30 gray or to 20 gray. As you can imagine, the results showed more significant grade 3 to 4 acute toxicity when patients had more cycles of chemotherapy and when they had a higher dose of radiation. So the toxicity was just significantly worse the more chemotherapy you gave, as well as the more radiation that you gave. Of note, 5% of patients developed second cancers approximately 7.5 years after radiation. And there was no significant difference in the development of second cancers between the two groups. So whether you gave 30 gray or 20 gray, it was just around 4 to 5% rates of second cancer. In terms of the outcomes, 97% of the patients had complete remission of disease, and the regimen of ABVD for 2 cycles followed by 20 gray were deemed non-inferior to any of the more intense options. So when they first compared the 4 cycles of ABVD versus 2 cycles, the failure-free survival was 93% versus 91%, and ABVD times 2 was non-inferior. And then in a second comparison, when they compared 30 gray of radiation versus 30 gray versus 20 gray of radiation, the failure-free survival was 93% in both groups. So again, non-inferior. And so the conclusion from German HD10 trial was that the progression-free survival is non-inferior with 2 cycles of ABVD followed by 20 gray of involved site radiotherapy for early stage favorable Hodgkin disease by the German Hodgkin study group criteria. And again, I make the caveat, I wrote ISRT there in that green box. Remember, they used IFRT because this trial was done more than 20 years ago. But in the modern era, we use ISRT. And then again, just to review which patients would have qualified for this trial, it's early stage favorable patients. So stage 1 to 2 disease, 1 to 2 nodes, no extranodal disease, a mediastinal mass ratio less than 1/3, and a low ESR. So these are the favorable early stage patients by German criteria. And then if they met those criteria, per the German HD10 trial, ABVD times 2 followed by 20 gray of ISRT was non-inferior. HD10 was done in a pre-PET era. So we were not using PET scans to assess the response to upfront chemotherapy. The next trial we're going to discuss was the German HD16 trial that did utilize PET scan, and they asked the question, if patients have a complete clinical response to ABVD times 2 cycles up front, and then they're negative on the PET scan, can we just omit any further radiation? And so they took patients with stage 1 to 2 favorable Hodgkin disease by the German Hodgkin study group criteria. And note that they did also include patients with the nodular lymphocyte predominant. So they had both the classic and then the non-nodular lymphocyte predominant Hodgkin lymphoma patients. But again, think of these as just early stage favorable Hodgkin patients. And they randomized them to either the standard of care based on HD10, which was ABVD times 2 cycles followed by 20 gray radiation for everyone, or a PET-directed approach where they treated with ABVD times 2 cycles followed by no further RT if they had a complete clinical response on the PET scan. And what is a complete clinical response? So in this trial, it was defined as a Deauville score of 1 to 3. Remember, 3 is where uptake is greater than the mediastinum but less than the liver. So anything 3 or less was considered PET negative, and these patients did not receive any further radiation. And then if they did have continued PET positivity, so a Deauville of 4 to 5, then the patients received 20 gray. Now, interestingly, what they found is that bulky disease, defined as greater than 5 centimeter disease, was more frequent among patients who had PET positive disease. So 34% of the patients with residual PET positive had bulky disease versus 18% in the patients that did not. And then the major outcome from this study is that the omission of radiotherapy was not non-inferior in terms of progression-free survival. And so the progression-free survival was 93% in the patients that received ABVD times 2 followed by 20 gray if they had a PET negative disease, versus 86% if they just received ABVD times 2 cycles alone and no further radiation. And so there was the omission of radiation in PET negative patients could not be considered non-inferior. And so the primary endpoint was not met in this study. Of note, the out-of-field recurrence was around 4 to 7% in both arms, so it was not significantly different. But the rate of in-field recurrence was only 2% with radiation versus 11% without radiation. So radiation really does provide a significant local control benefit, and that translates to a progression-free survival benefit of, somewhere around 7 to 10%. Of note, the overall survival was similar in both arms at 98%. And the reason that the overall survival was not worse is because there is a good salvage option. So the patients that failed after receiving ABVD alone ended up undergoing salvage chemotherapy with or without autologous stem cell transplant to maintain equivalent overall survival. So the conclusion from the German HD16 trial is that ABVD alone for 2 cycles with observation is not non-inferior for progression-free survival in patients that are PET negative. So for favorable early stage Hodgkin disease, if they do get 2 cycles of ABVD and then have a complete clinical response on PET scan, we still need to give them 20 gray adjuvantly to maintain that progression-free survival. However, note that the overall survival was very similar in both arms. And because there's a good salvage option of chemotherapy, plus or minus autologous stem cell transplant, we do maintain that overall survival between the 2 groups. And so I think this is where a bit of controversy and just discussion really is generated, because the question is, what is better for patients? Is it better to undergo just 2 cycles of ABVD and then 20 gray of radiation, or do we just watch them and then salvage with further chemotherapy and transplant if needed? It's always a risk-benefit situation, and it's important to kind of keep in mind that ABVD is also not without toxicity. Each cycle of ABVD is thought to be equivalent to around 4 gray of a mean heart dose. And so at some point, when you keep adding more cycles of chemotherapy, you might sway yourself towards just pursuing radiation therapy to avoid further chemotherapy when you can. And so it's definitely an area of discussion, but it's important to be aware that, radiation does provide a significant PFS benefit for these patients. It's not non-inferior to omit the radiation entirely. Okay, so HD10 and HD16 are trials from the German Hodgkin study group, and for patients that are considered early stage favorable per the German criteria, are acceptable candidates for ABVD times 2 followed by 20 gray ISRT. And remember, we always do ABVD times 2. We assess clinical response with a PET scan, and assuming that the patients do have a complete clinical response, we can treat with 20 gray ISRT. Now, We're going to move on now and talk about some EORTC studies for early stage favorable. And so I want to take a moment to just go back to the risk factors and talk about what qualifies as early stage favorable per the German versus EORTC. So for EORTC, the biggest differences compared to the German criteria are that 1 to 3 nodal sites are considered favorable, whereas for German, only 1 to 2 were considered favorable. If you had 3, that automatically made you unfavorable. Also for EORTC, we really care about the age. So if you're less than 50 years old, you can be favorable, but if you're 50 years or older, that automatically makes you unfavorable. And then with German, they did care about having an extranodal lesion. With EORTC, that is not a criteria, but having a mediastinal thoracic ratio greater than 0.35 and having an elevated ESR, those are risk factors that are pretty consistent between EORTC and German. So the biggest differences for EORTC versus German are 1 to 2 sites is considered favorable for German, but 1 to 3 is considered acceptable for EORTC. And the way I remember that is that if you write the number 3 backwards, so if you kind of flip it, the mirror image along the vertical axis, a 3 becomes an E. So EORTC allows you to have 1 to 3 nodes, whereas the Germans only let you have 2. And then for EORTC, we also care about the age. So age greater than or equal to 50 makes you unfavorable. The other point I want to review from the overview lecture is that, remember, the German study group versus EORTC also group the lymph node regions differently. So the biggest difference, I think, is if you think about above the diaphragm and specifically the infraclav and subpectoral nodes. So Germans group the infraclav/subpectoral nodal region along with the cervical and supraclav. So for the German Hodgkin study group, infraclav and supraclav are together. For EORTC, the infraclav is grouped with the axilla, so more like your traditional breast nodal regions that you think about. So German, the infraclav goes with the supraclav. For EORTC, the infraclav goes with the axilla. And remember, both German and EORTC study groups consider the mediastinum and bilateral hyla as just one group. So the point I'm trying to make is that if you have an infraclav node, an axillary node, and then say a mediastinal node, by German criteria, that would be considered 3 lymph node regions, making the patient unfavorable early stage. By EORTC criteria, that would actually just be considered 2 lymph node regions. And even if they had 3 lymph node regions, by the EORTC criteria, they would still be considered favorable. And so this is where I think it gets a little bit confusing. And whenever you are kind of risk stratifying patients as favorable versus unfavorable and determining a treatment paradigm for them, you really have to be conscious of which study groups paradigm you're using for grouping the lymph node regions and counting them, for classifying them as favorable versus unfavorable, and then whichever study group you classify the patient based on is the study group that you should sort of treat the patient based off of as well. So now that we understand that EORTC and German Hodgkin study group the lymph nodes differently, and they have slightly different factors that make you favorable versus unfavorable, we realize that patients that are considered favorable by the EORTC criteria might not necessarily be considered by the German criteria. So as long as you understand that there are some subtle differences in terms of how these patients are grouped together, I think that is the major point here. So we talked about German HD10 and HD16. We're now going to move on and talk about EORTC H10, which was a trial that asked the question, can we omit involved nodal radiation in patients that are PET negative after 2 cycles of ABVD? And this is a very similar question actually to the question that was asked by the German HD16 trial, but what EORTC did is that they took patients, and let's just focus on the favorable arm for now. We'll talk about unfavorable when we're talking about unfavorable disease. Let's just focus on H10F, which is the favorable arm. They randomized patients to either 2 cycles of ABVD followed by a PET scan, and regardless of the response, they received an additional cycle of ABVD plus INRT, so 3 cycles of ABVD chemo followed by radiation, or they were randomized to 2 cycles of ABVD and then treatment tailored based on the PET response. So in that tailored arm, if they were PET negative, they just received 2 more cycles of ABVD and no further radiation. If they were PET positive, then they received 2 cycles of escalated Bayakop. Remember, that is the more aggressive form of chemotherapy, just a very much aggressive regimen. So if they were PET positive, so if they had partial response or residual disease, they got escalated Bayakop for 2 cycles, followed by radiotherapy. And keep in mind that, the German trials that we talked about were using involved field radiation. The EORTC trials were using involved nodal radiation because they were run in Europe. Here we would do involved site radiotherapy, but involved node radiation, so smaller fields compared to the German trials that we talked about previously. So just to review the 2 arms of EORTC H10F, the standard arm was ABVD times 3 followed by 30 gray. And if they were in the PET-directed tailored arm, they were treated based on their PET response. So a Deauville 1-2 was considered a negative PET response, and everything else was considered a positive PET response. So that's another subtle difference, right? Because the German study group considered Deauville 1-3 as negative, and EORTC considered Deauville 1-2 as negative. But if there was a Deauville 1-2 response, then patients were considered PET negative, and they were just treated with ABVD for 4 cycles total. But if they had PET positive disease, then they were treated with ABVD times 2 followed by escalated Bayakop followed by 30 gray of radiation. And interestingly, the results of this study were very similar to what we saw in HD16, where the progression-free survival was not non-inferior with ABVD alone. So in patients that were PET negative, Deauville 1-2 after 2 cycles of ABVD, if they were treated with radiation, or if they were treated with ABVD for 1 more cycle plus radiation, then the 5-year PFS was 99%. However, if they were treated with just 4 cycles of ABVD total, then their PFS was 87%, so just around a little over 10% less. The 5-year overall survival rates, again, were very similar in both arms, 99 to 100%, not significantly different. But the PFS, again, was not non-inferior, and it was around 10% worse in the patients that did not receive any radiation. In terms of the PET-positive patients, the 5-year progression-free survival did improve with escalated Bayakop. So the 5-year PFS was 77% with ABVD plus INRT, in the standard arm versus 91% in the Bayakop escalated times 2 plus INRT. However, Bayakop is a very, very toxic regimen and has significant rates of grade 3 to 4 hematologic toxicity. So it's actually not really used in the US. It's more commonly used in Europe, but we really don't use it in the US. But the big takeaway from EORTC H10F is that even with an excellent PET response, so Deauville 1-2, ABVD alone is not non-inferior to ABVD times 3 plus 30 gray INRT. And again, there was no significant difference in overall survival. I think these results very sharply mirror what we saw in HD16. And keep in mind that in H10F, they were looking at even more quote-unquote favorable patients because they had such an excellent response. They didn't even include Deauville 3 response. But despite that, there was more than 10% PFS benefit with the addition of radiation. So from EORTC, we then get the treatment paradigm of ABVD times 3, followed by 30 gray of radiotherapy. The last trial I'll mention for early stage favorable disease is UK Rapid, from which we get the treatment paradigm of ABVD times 3 cycles and no further therapy if patients are PET negative. So this trial took patients with stage 1A to 2A classical Hodgkin disease. They took non-bulky disease, but actually around 30% of patients were unfavorable based on German and EORTC risk criteria. And they were treated with ABVD times 3 cycles followed by a PET scan. And if they were PET negative, they were randomized to no further therapy versus 30 gray of involved field radiation. And if they were PET positive, then they received a total of 4 cycles of ABVD followed by 30 gray involved field radiation. And what they found is that the 3-year progression-free survival, again, was not non-inferior with ABVD alone. So just like we saw in HD16 and then EORTC H10F, radiation does seem to confer a progression-free survival benefit. However, if you look at the absolute values, the 3-year PFS was 95% with the radiation group versus 91% with no radiation. So still very good progression-free survival. It was just not non-inferior with the omission of radiation. The 3-year overall survival, just like we saw in those other trials, was excellent, 97 to 99% in both arms. For the patients that were in the PET positive arm, the 3-year progression-free survival was 88%. Remember, they got ABVD times 4 followed by 30 gray of involved field radiation. And then there was a subset of patients that did undergo progression and underwent stem cell transplant. So UK Rapid just adds evidence to our growing bank of studies that show that ABVD alone is not non-inferior to ABVD plus radiation, even in patients that are PET negative. However, we know that they have excellent overall survival, and that is because there are good salvage options. And the PFS in UK Rapid was actually fairly good in both arms, so 91% with the omission of radiation versus 95% with radiation. So I think the major takeaways for early stage favorable classical Hodgkin disease, it has a very excellent prognosis with a progression-free survival of somewhere around 90% and an overall survival of probably somewhere around 99%. So these patients do very, very well, and they have a lot of treatment options. A lot of folks will favor omitting radiation to spare patients the toxicity of radiation. And it's true that radiation does cause significant long-term toxicity in the sense of cardiac toxicity as well as risk of second malignancy. But know that when we do omit radiation, although patients still have an equivalent overall survival, the progression-free survival is not non-inferior in any of these studies. And based on the studies that we talked about, radiation provides an absolute progression-free survival improvement of somewhere in the neighborhood of 7 to 10%. So in terms of a treatment paradigm, when you're asked how would you treat a patient with favorable early stage disease, ABVD times 2 followed by a PET scan is always a great way to start off. So you do 2 cycles of ABVD, get an interim PET scan. If the patients have a Dovil 4 response, so meaning a partial response to upfront chemotherapy, then we know that we need to give them more chemotherapy because they did not respond as well as we would have liked to the upfront 2 cycles. So if they're Dovil 4, then they get more ABVD, so 4 cycles total. And then if they have a good response to that, we can treat them with 30 gray of involved site radiation. So ABVD times 4 followed by 30 gray. If they have a Dovil 1 to 3 response, however, we have several treatment options. So ABVD times 2, PET scan, and then 20 gray of radiation if they're favorable per the German Hodgkin study group criteria. If they are favorable per the EORTC H10F criteria, we can always do ABVD times 3 followed by 30 gray. UK Rapid does actually give us some evidence for just treating solely with ABVD times 3 to 4 cycles. And even with EORTC H10F, remember the overall survival for the patients that were treated with just ABVD times 4 was pretty comparable to the patients that received radiation. It was just the progression-free survival that was worse. And then another trial that we will talk about when we get to our advanced stage section is UK Rathel. There is an option to do ABVD times 2 and then actually drop the bleomycin and do 4 more cycles of AVD alone. So there is some data for that, which we'll talk about down the road. But just remember, ABVD times 2, assess the PET response. If they have a poor response, they need more chemo and 30 gray radiation. But if they have a good response, then we have many different options based on the trials that we talked about. So moving on now, let's talk about early stage unfavorable disease. And remember, these tend to be patients that have multiple nodal sites, so 3 or more per the German, 4 or more per EORTC, and they also often have bulky disease. So starting with the German Hodgkin study group, HD11 was a trial from the German Hodgkin study group that looked at unfavorable early stage disease. And the treatment paradigm that emerges from this trial for unfavorable disease is ABVD times 4 followed by 30 gray. So this trial included patients that were considered unfavorable per the German criteria, and they underwent a 2-by-2 randomization. So the randomization was to Beacop for 4 cycles versus ABVD for 4 cycles, and the second randomization was 30 gray versus 20 gray of involved field radiation. And across all of the arms, the overall survival was excellent, 93 to 95%. And when they compared the radiation dose with ABVD, they found that 20 gray was not non-inferior to ABVD times 4 plus 30 gray. So the 5-year PFS was 82% with ABVD times 4 followed by 20 gray versus 87% in all of the other arms. So the Beacop arms actually both did really well. Whether they got 20 gray or 30 gray, the outcomes were equivalent. However, Beacop was associated with significantly higher hematologic toxicity, very, very rough for patients to tolerate. And so the standard arm that was preferred from this trial was ABVD times 4 followed by 30 gray. That was equivalent to Beacop times 4 followed by 30 gray or 20 gray. But remember, Beacop had significant toxicity, and ABVD times 4 followed by just 20 gray had worse progression-free survival. So ABVD times 4 followed by 30 gray is the standard for early stage unfavorable disease based on German HD11. Now this trial was again performed in the pre-PET era. In the modern era, we would look for PET response after ABVD times 2 to make sure we're on the right track, and then patients would get ABVD for 4 cycles total, followed by 30 gray of radiation. So that was the German trial for unfavorable disease. We're back now to EORTC H10, and this time we're going to focus on H10U, which is the unfavorable arm. And very similar to H10F, they took patients with unfavorable disease this time and randomized them to standard, which was 4 cycles of ABVD followed by INRT, versus 2 cycles of ABVD followed by treatment based on the PET response. So PET negative patients received 4 additional cycles of ABVD for a total of 6 cycles, and PET positive patients, just like in the favorable arm actually, received 2 cycles of escalated Beacop followed by INRT. And I think no surprises here, but just like we saw with EORTC H10F, it turns out that PFS was not non-inferior with ABVD alone. So PFS not non-inferior if we omit radiotherapy. The 5-year PFS was 92% with ABVD times 4 plus INRT versus 90% with ABVD alone. And so the conclusion is not non-inferior because it did not meet the threshold for non-inferiority. But if you look at the absolute values, again, 92% versus 90%, one wonders, how much of an absolute benefit does that really provide? And when you look at the overall survival, it was 97 to 98% in both arms. And so, again, you can see why, folks may draw the conclusion that we understand that the progression-free survival is not non-inferior with the omission of radiation. However, it's still really, really good. And because the salvage rates are so good, maybe we can just spare the patients the toxicity of radiation. Again, I think this is a very common thread. We saw this in favorable, we see it again in unfavorable, but the progression-free survival is not non-inferior with the radiation, but it's still very good. In terms of the escalated BACOP arm for the PET-positive patients, again, the 5-year progression-free survival did improve with the escalated BACOP, but again, we saw higher grade 3 to 4 hematologic toxicity. Jumping back to the German Hodgkin study group for a second, I want to mention that this 2+2 chemotherapy regimen that you might hear about, which came from the German HD14 trial. So this was a study of patients with early stage unfavorable disease, just like HD11, so unfavorable by the German criteria. And they randomized patients to either ABVD times 4 followed by 30 gray of radiation, or the 2+2 chemo regimen followed by 30 gray. Now, what's 2+2? 2+2 is 2 cycles of BACOP and 2 cycles of ABVD, and then they followed that up with 30 gray of radiation. Their primary endpoint of freedom from treatment failure actually improved with the 2+2 regimen. So the 5-year PFS was 95% with 2+2 versus 89% with ABVD times 4. So there was a 6% absolute improvement. There was no significant difference in overall survival between the two arms, however, and there was significantly higher acute toxicity with the 2+2 regimen. So I think it's quite striking. The grade 4 toxicity was 56% with 2+2 versus only 6% with ABVD. And the grade 3 to 4 was 80% versus 51%. So really, really bad toxicity. And, you should know that intensification of therapy with BACOP is definitely more standard in Europe in general. In the US, it's generally less accepted because it increases toxicity. It does improve progression-free survival, but since it does not provide an overall survival benefit, it's generally less accepted in the US. And so the UK, I think, tends to use both BACOP and radiation more commonly compared to the US. But I just want to mention, this regimen, which you might hear about. And then following HD14, the German HD17 trial was published that looked at radiation omission based on the PET response. And interestingly, so if patients, the PET guided response was BACOP times 2 plus AVVD times 2, so the 2+2 regimen. And they only treated with 30 gray of radiation if patients had Dovel 3 to 5 disease. So remember, Dovel 3 was considered PET positive here. Dovel 1 to 2 were considered negative. And it turned out that 68% of patients in the PET guided arm had a Dovel of 1 to 2 after the 2+2 regimen, and radiation was omitted. And when they looked at the progression-free survival, it was actually non-inferior with PET guided omission. So the progression-free survival was 97% with the standard arm versus 95% with PET-guided omission, and that did meet the non-inferiority criteria. So all these studies that we've done so far showed that with the omission of radiation, progression-free survival was not non-inferior. It turns out that when we use escalated chemotherapy, so the 2+2 regimen of BACOP times 2 followed by ABVD times 2, if patients have a Dovel response of 1 to 2, then we can omit radiation. And 68% of patients avoided radiation in this trial. So again, BACOP is not something that we standardly utilize in the US, but I think it is good to be aware of this trial. So I think the highlights from our discussion of early stage unfavorable disease, again, in the US, we're very unlikely to use BACOP just because it is an extremely, extremely toxic chemotherapy regimen. Again, ABVD times 2 followed by a PET response is always a great way to start off when you're asked how you would treat somebody. And then response kind of based on the PET response, we can kind of tailor further therapy. And assuming that they have a good response, generally considered Dovel 1 to 3, our treatment options include ABVD times 4 cycles total, followed by 30 gray as an EORTC H10U. Or again, we can consider ABVD times 2, followed by AVD times 4, as per the UK RATHL trial, which we will talk about soon. The radiation, the biggest differences to keep in mind, so with early stage favorable, remember ABVD times 2 followed by 20 gray, as per the Germans, or ABVD times 3 followed by 30 gray as per the EORTC. That was kind of the standard treatment paradigm for favorable. And then for unfavorable, it's ABVD times 4 followed by 30 gray. And so finally, this brings us to management of advanced disease and the evidence for our management there. Remember, advanced disease is disease that's stage 3 or 4. So involvement of both sides of the diaphragm or significant extranodal disease burden. German HD15 trial compared Bayakop times 8 cycles versus Bayakop times 6 cycles versus 8 cycles of dose-dense Bayakop, so given every 2 weeks instead of, I believe, every 3 weeks. And this was for patients with advanced stage, so stage 3 to 4 Hodgkin's disease. And I won't spend too much time on this because we don't really use the Bayakop regimen in the US. But basically, there was a significant overall survival benefit to Bayakop times 6 versus Bayakop times 8, probably because there was less toxicity with Bayakop times 6. And of note, all of the 3 groups in this trial did receive 30 gray of PET-guided radiotherapy for lesions that were 2.5 centimeters or greater that had residual FDG uptake. But again, Bayakop times 6 versus Bayakop times 8 actually showed a significant survival benefit to Bayakop times 6. Again, Bayakop not very commonly used in the United States at all. So I actually think UK Rathel is a more relevant trial to us here in the US and, helps us to guide further risk-adapted therapy for Hodgkin's disease. So UK Rathel took patients with advanced Hodgkin's disease who had a baseline PET-CT followed by 2 cycles of ABVD. And then again, they tailored the response based on the PET. So after 2 cycles of ABVD, if they had a Doval 1 to 3 response on PET, considered PET negative, they were randomized to either ABVD times 4 cycles or AVD times 4 cycles. If they had a positive response, so Doval 4 to 5 after 2 cycles of ABVD, then they received 3 cycles of escalated Bayakop followed by an additional PET-CT, and then escalated Bayakop times 1 or dose-dense Bayakop 14 times 2 if they were PET negative. No radiotherapy was given if the interim PET was negative, but they did, in the study, they said that they allowed radiation at the discretion of the physician. Unfortunately, radiation was not a randomized variable in this trial, so it's kind of difficult to draw any conclusions about radiation from this study. But anyway, 84% of the patients were PET negative after 2 cycles of ABVD, so they had Doval 1 to 3 response. And the progression-free survival was very, not super different between the 2 groups when you look at absolute values. So PFS was 84% with AVD versus 86% with ABVD. Again, it's one of those situations where they were not able to conclude that 2 cycles of ABVD followed by 4 cycles of AVD, dropping the bleomycin, was non-inferior. So it was not non-inferior, but again, the absolute difference between these 2 groups was very low, only 2% here. And the overall survival was extremely similar in both arms, 97% to 98%. And so, for these patients that had PET negative disease after 2 cycles, UK Rathel showed very good outcomes with ABVD times 2 followed by AVD times 4. And the major advantage of doing this is decreased pulmonary toxicity because you drop the bleomycin, which, remember, causes significant pulmonary toxicity. And so ABVD times 2 followed by AVD times 4 is, a regimen that is utilized in the US because we understand that the PFS was not non-inferior. However, the absolute difference was very low. The overall survival was extremely comparable. And, we get to drop that bleomycin. And this regimen also does not actually utilize any radiation. So this was sort of the interpreted conclusion of UK Rathel. I'll also mention that of the PET positive patients in UK-RATHL, 74% actually had a clinical response, a clinical complete response after 3 additional cycles of Bayakop. And the 3-year progression-free survival was 68%. The 3-year overall survival was 88%. So, obviously these patients do a little bit worse because they have advanced stage Hodgkin's and they did not have a good response to upfront 2 cycles of ABVD. But they did have a pretty good response when they got the escalated Bayakop. So the big conclusion from UK-RATHL, I think, is ABVD times 2 followed by AVD times 4 for advanced stage disease is technically not non-inferior, however, low absolute difference in PFS. And many centers will use this regimen and even extrapolate it to early stage disease, as we saw earlier. There are a couple of trials from the Italian study group that I think are worth mentioning that investigated the role of consolidative radiotherapy for advanced stage Hodgkin disease that had a complete clinical response to ABVD. So HD 0607 took patients with advanced Hodgkin disease and bulky nodal mass, so greater than or equal to 5 centimeters. And these patients had to have a negative PET at cycle 2 after ABVD as well as after cycle 6, so complete clinical response. And they were randomized to either consolidation radiotherapy to 24 to 36 gray or no further treatment. The patients were then stratified based on the size of their tumor, so 5 to 7 centimeters versus 8 to 10 centimeters versus greater than 10 centimeters, which is what we classically think of as bulky, greater than 10 centimeters. And as you can see from the progression-free survival in the green table on the right-hand side, there was no significant difference in the progression-free survival between the groups in any of the different subgroups with the addition of radiotherapy. Now, of note, I think this trial is difficult to interpret because the trial was not actually powered for a radiotherapy comparison. There was an additional randomization for the patients that were PET positive after 2 cycles of ABVD. Those patients were randomized to 4 cycles of Bayakop plus or minus rituximab. And then the trial actually showed no benefit to rituximab. The 6-year progression-free survival was around 60%. Overall survival was around 90%. So that was for the PET positive arm, escalated Bayakop plus or minus rituximab, and it was negative. But in this PET negative group, after 6 cycles of ABVD, it seemed like there was not a benefit to consolidative radiotherapy, regardless of how bulky the tumor. Again, the trial was underpowered for this comparison, but that's sort of the conclusion. Another study from the Italian group that also, I think, sort of muddies the waters and doesn't totally answer our question about the role of consolidative radiation was HD 0801. And they took patients with advanced disease and randomized, after ABVD times 6 cycles, randomized them to either consolidation radiotherapy or observation. And they found that there was no significant improvement with the addition of consolidative radiotherapy. The 2-year event-free survival was 88% with radiation versus 86% without radiation. And the 2-year progression-free survival was 91% with radiation versus 86% without radiation. And so this trial showed no significant benefit to consolidative radiotherapy if they had negative PET after cycle 2 as well as after cycle 6 and 6 cycles of ABVD. And these, again, were bulky lesions greater than 5 centimeters. The reason I think this trial is not totally informative is because it was powered to detect a 20% benefit. And remember from our earlier studies, the German HD10, HD16, even EORTC, remember that the progression-free survival benefit from radiation was somewhere on the order of 7 to 10%. And so if the trial was powered to detect a 20% benefit, then of course it was negative. So it's, again, I think difficult to draw a conclusion from this trial as well. But based on these 2 Italian studies, there's no evidence for consolidative radiotherapy in patients with advanced stage disease and bulky lesions measuring greater than 5 centimeters who have a complete response after 2 cycles of ABVD, and then again after 6 cycles of ABVD on PET scan. There is an alternate systemic therapy option for advanced stage Hodgkin lymphoma, which is BV-AVD for 6 cycles, and this is based on the Echelon 1 trial. So BV stands for brentuximab vedotin, which remember is an anti-CD30 antibody. And we use it because Hodgkin lymphoma is CD15 and CD30 positive. So we use this BV, which is the anti-CD30 antibody. And the Echelon 1 trial randomized patients with stage 3 to 4 disease to either ABVD times 6 every 28 days or BV-AVD for 6 cycles every 28 days. And of note, they did switch to the alternate arm if after 2 cycles their PET was still Deauville 5. So then they switched to alternate therapy. The 2-year progression-free survival in this study was 82% with BV-AVD versus 77% with ABVD. I think it's basically a toxicity trade-off. So we know that ABVD causes worse pulmonary toxicity, but BV-AVD causes significantly worse neuropathy. So the grade 3 or plus pulmonary toxicity was 1% with BV-AVD versus 3% with ABVD. Neuropathy, however, was 67% with BV-AVD versus just 43% with AVD. So BV-AVD is another FDA-approved systemic therapy to be aware of for advanced Hodgkin lymphoma. However, its limitations are neurotoxicity and cost, but it did have a progression-free survival benefit that was significant compared to standard ABVD. One other trial I think that we should be aware of is SWOG S1826. As far as I know, the abstract for this study was presented at ASCO 2023, and we are still awaiting publication. But this trial looked at different systemic therapy. So they compared, for patients with advanced stage Hodgkin disease, BV-AVD, which was established based on Echelon 1, compared to nivolumab and AVD. So BV-AVD compared to nivo-AVD. And nivolumab is an immunotherapy that is a PD-1 inhibitor. And the primary endpoint was progression-free survival. And in fact, it was significantly improved. So the 1-year progression-free survival, when they presented the abstract in ASCO 2023, the 1-year progression-free survival was significantly improved with nivo-AVD. So it was 94% in the nivo arm versus 86% in the BV-AVD arm. There was lower peripheral neuropathy with the nivolumab, but greater grade 3 or worse hematologic events. So obviously we need longer follow-up. Survival data are probably maturing, but I think SWOG S1826 is an important study to be aware of as well, because it's looking at an alternative to BV-AVD, which is nivolumab AVD. So that concludes our discussion on advanced stage literature. And I think the major takeaways here are that most patients with advanced Hodgkin lymphoma will have a good response to 6 cycles of ABVD. And we don't really have good evidence for radiation, even if they have bulky disease, if patients have negative PET scans after 2 cycles and then after 6 cycles of ABVD. So those were those Italian studies that we talked about, and it seems like it is safe to omit radiotherapy, even if they had upfront bulky disease. Possible indications for involved site radiotherapy include patients that presented with initially bulky disease, so greater than 5 centimeters, and PET positive disease after 2 cycles of ABVD, so they did not have a complete response to 2 cycles of ABVD, or if they continue to have residual PET positive disease after the conclusion of chemotherapy. So here's a quick summary slide to kind of hopefully cohesively summarize everything that we have talked about in terms of a treatment paradigm for Hodgkin disease. So regardless of what stage, whether it's early stage favorable, unfavorable, or advanced, it's always correct to start with ABVD times 2 cycles and then have a PET for response assessment. Most patients will respond well to the therapy, and typically a complete clinical response is described as Doval 1 to 3, although remember there were some select studies that we talked about that characterized Doval 1 to 2 as a complete response. But most people accept Doval 1 to 3 as a complete response. And most of the patients will respond well, and we can continue along the different pathways that are outlined here. If they do not respond, then we need to escalate. And Bayakop is a regimen that's often used in Europe, but we know that it has very significant toxicity. Here in the US, I think it's more standard to just give more cycles of ABVD or try BVAVD, but kind of, escalating the chemotherapy, giving them additional chemotherapy. So ABVD times 2 followed by a PET. And then for early stage favorable, if we use the German criteria, ABVD times 2 followed by 20 gray is an option. If we use EORTC criteria, ABVD times 3 followed by 30 gray is an option. And then there are also options where we omit radiotherapy, understanding that there is a decrease in progression-free survival, but overall survival is still very good. And those regimens include ABVD times 3 to 4, as in UK Rapid, or ABVD times 2 followed by AVD times 4, as in UK Rathel. For early stage unfavorable, we have to give a little bit more chemo. So ABVD times 4 followed by 30 gray, or ABVD times 2 followed by AVD times 4. And then for advanced disease, again, the UK Rathel paradigm is possible. So ABVD times 2 followed by AVD times 4, or ABVD times 6 with consideration of 30 gray involved site radiotherapy only if they had initially bulky disease and PET positive after 2 cycles of ABVD, or if they continue to have residual PET positive disease after the full 6 cycles of ABVD. And then BVAVD times 6 is also an option as per echelon. And then be aware of the SWOG study that we talked about that is looking into nivolumab AVD. So remember, again, all of these pathways are assuming that the patient has a Doval 1 to 3 response after 2 cycles of ABVD. And then if they have a Doval 4 to 5 response, then escalation of therapy is definitely warranted. So that is all I have. Hopefully this talk helped to shed some light on treatment paradigms for Hodgkin lymphoma in an evidence-based manner. Hopefully it was helpful, and thank you so much for your time.